Good evening. My name is Jessica Myrie, and I am an RN BSN. This is my MSN evidence-based educational project. My population of interest was Black Americans in rural areas ages 55 to 85, and I chose managing hypertension in that demographic. Today, we'll discuss addressing hypertension in African Americans age 55 to 85 in the Wilcox community in Alabama. This project emphasizes on the role of a community-based interventions to improve cardiovascular health outcomes and reduce disparities. Our goal is to highlight evidence-based strategies that could and better health support better health outcomes in this population. Some background. Wilcox community has a predominantly Black population facing economic challenges and limited healthcare access. This contributes to high rates of hypertension in the community, impacting health outcomes significantly. Nationally, Black Americans face a higher prevalence of hypertension, and it's a trend that's even more pronounced in Wilcox community. As I stated, hypertension affects nearly 50% of Black Americans in the Wilcox community, highlighting a stark health disparity. Cardiovascular disease mortality rates are disproportionately higher in this community, largely due to uncontrolled hypertension, underscoring the need for this targeted intervention. Excuse me. Hypertension is the leading risk factor for heart disease, stroke, and kidney failure. Disproportionately, this affects Black Americans. Addressing this through community and culturally tailored intervention is crucial to improving health outcomes for this community. And this is some of that background information I stated before, and it's just that information continued through my literature review. I found that hypertension is the leading risk factor. I apologize. Through my research, it showed community-based cardiovascular awareness programs are effective, especially when they involve local partnerships like churches, barbershops. Um, it enhances education and community participation. That's what through community involvement. Mobile health applications, such as MedSafe, have shown promise in improving medication adherence and blood pressure control. This digital tool offers personalized reminders and educational support, especially beneficial to underserved communities. And it's MedSafe is an app that you can download. And we utilize this in a lot of the homes that had families. It was a multi-generational home where it was younger adults living in the home that could better navigate the app to help self-monitor blood pressure and medication adherence for the population that we were studying. Community-based culturally tailored education, or CBCTE. This is an intervention that integrates community and technology-based approaches such as MedSafe, as I spoke about earlier, to help hypertension self-management. CBCTE integrates local engagement and technology to empower individuals in managing their hypertension. This approach has led to improve medication adherence and blood pressure management. And through the literature review, we utilize the Roy theory of nursing practice. And through this theory, the Roy's theory of adaptation, it supports tailored nursing interventions for managing hypertension. This model supports personalized care intervention and how patients respond to hypertension related stressors, aiming to improve adaptation and self management. The health belief module um, During this module, it um it was also with prevention and having focus on individuals' perception of severity of the benefits and the barriers of their health actions, effective in designing culturally sensitive health programs to improve health behaviors and outcomes. During the gap analysis, with the gap analysis, it identified a need for community-based hypertension programs and improve access of healthcare services. Wilcox lacks uh, a sufficient amount of resources for effective hypertension screening and management. This area has, in the area that we visited the most, it had one primary care um, facility, and within maybe a 50 to 100 mile um, radius. I think the closest hospital in that area that we um, spent majority of our time, it probably was about 50 miles away. It was, so the primary care provider was almost like a urgent care for some of the citizens living within the community. Through our windshield survey and the interviews, it revealed a limited healthcare, as I said before, in facilities and significant socioeconomic barriers for the Wilcox community. Um, I interviewed various members of the community. Some were on the city council, the local church boards, a few, most were residents of the community during the preceptorship, and it highlighted the need for culturally competent education and family involvement in the hypertension management. And some more information about that. Some of the strengths would include a strong community engagement potential, while some of the weakness involved limited resources and cultural health seeking barriers. The opportunities exist could I felt were that could be beneficial was the telehealth services that the company I did my preceptorship with did provide. But socioeconomic disparities remain a threat to the sustainable um, health outcome. Going back to the Royce theory of adaptation, in this project, we wanted to make sure we were tailoring our nursing care to enhance the self management and health outcomes in these clients with hypertension. Bar health belief model approach was primary prevention. We wanted to do health education, community based awareness campaigns, and lifestyle modification. Secondary prevention would be regular blood pressure screenings, early detection, and intervention. Tertiary prevention is disease management and programs, medication adherence, and support of lifestyle counseling. The environmental, individual, and aging factors. The environmental factors that we ran into are the limited access to healthcare facilities, food desert. Wilcox County is the food desert, so access to healthy foods that was an issue. Of course, the socioeconomic challenges, individual factors, health behaviors, and adherence to medication and cultural beliefs. A lot during my preceptorship, it was a lot of cultural beliefs when it came to adhering to medication regimens. Aging factors, role of the healthcare providers. We did visit some, well, the one healthcare facility in that community to speak with the attending physician in that area, um, to help promote more patient education and patient teaching when it comes to monitoring blood pressure and medication adherence. With the evidence-based education project continue, you can see um, it's the high prevalence of African Americans and above with uncontrolled hypertension. It's limited access to healthcare services in the area, and it's a low health literacy and awareness in regarding to hypertension and prevention for these clients. So the priority community diagnosis was uncontrolled hypertension among African Americans, adults aged 55 and above in the Wilcox community, leading to increased risk of cardiovascular disease and mortality. The population interventions of focus, we wanted to implement patient and family education programs to improve knowledge and skills in hypertension management. We wanted to get the family involved. It was not just one client centered. If they live with family, we wanted to teach the entire family on adhering to your blood pressure medication regimen or your medication regimen in general, lifestyle changes, exercise, incorporating some form of exercise and dietary changes, small dietary changes. Using the 5 sub roles of a AP advanced practice health nurse to promote healthy people. 2030, the researcher conducted studies to identify the effective strategies for hypertension management and disseminated the findings to healthcare providers. So I conducted a study to see what would be best suitable for my clients, and that was a lot of education. The clinician educator delivered evidence-based interventions and educated patients on the lifestyle changes. As I stated before, we collaborated with local community, the local church in that area. We collaborated with them to um, provide classes and attend health fairs. Where we also did education. We advocated for change. Again, we visited the local I'm sorry, primary care office to speak with the primary care doctor to encourage and promote health equity and addressing social determinants leadership. Um, we led again a class taught by myself um, at one of the churches. We wanted to enhance patient and family knowledge. So, like I said, education was very a key component in this study. Some of the barriers, it was limited financial resources in the community, potential resistance. We did get some resistance from uh, some participants. Challenges of reaching a remote areas and ensuring consistent participation. With that, we brainstormed and we looked into uh, a service that the company provided. What was the wellness coaching? Some challenging, overcoming logistical issues such as transportation and access to healthcare facilities, addressing diverse healthcare literacy levels, and maintaining ongoing engagement. Um, a lot of our clients we saw annually, with a few that we did see semi-annually. So making sure when we were with them, we were very encouraging with them. Project implementation, conducted initial community assessment. We implemented patient and family education. We monitored the progress for those that we could, that we did see semi-annually. We evaluated. I recognize the importance of interdisciplinary collaborating, working with, even though we did have limited resources, we came together to work together to implement a plan